Well, thank you, and that was, the last two talks are wonderful setups to my talk. I'm going to go back into newborn screening a little bit. I want to thank the organizers for inviting a presentation from the newborn screening program perspective, and I'd like to thank many of my colleagues in newborn screening, at APHL, at the CDC, and some of the people who are here for participating in discussions about how next-gen sequencing will fit into newborn screening for discussions that have gone on for a long time. So we all know that newborn screening is a public health program that's authorized by the state to ensure the health of our infants. Early identification, early treatment, state authority required, and state authority required so that it is universal, so that there is no health disparities in our population. And for any technology, we know that there are things that the technology offers, that our experience offers, things to learn. And I've been asked to talk to you mostly about what it is that our newborn screening experience has to offer to current and future practices of newborn screening. Now, we're used to looking at or thinking about the numbers of conditions that are on newborn screening panels, and to use that as a marker of how advanced we are. But I thought it was important for us to also consider the relative proportions of babies who are identified by our panels. And, excuse me, of course the numbers and proportions don't tell it all. Some of the conditions are more insidious than others. Some of the conditions are more treatable than others. Clearly, though, all of these conditions are conditions that already have a biochemical analyte that make it fairly easy for us to screen. Because of this, we're using currently a multiplicity of assays. And I do have to say that I think it's very important that we who are educated people are very careful with our language. Our testing is accurate. Our communications, once they've gone from us to the pediatrician, to the nurse, to the parent, might not be so accurate, but the testing is accurate. So we use a multiplicity of tests, whether it be the HPLC for hemoglobinopathy testing, Delphia for endocrinopathy, and the first tier of CF screening, tandem mass spec for a variety of biochemical disorders, and more traditional biochemical assays for other disorders, and DNA testing, real-time PCR, and other DNA assays. In the U.S., though, a screening program is going to call a primary care provider at the front line of defense, the primary care provider who interfaces with the parent on extremely high-risk results every 3 minutes. We may not know who the PCP is. In fact, 30 to 40% of the time, we don't know who the PCP is, and we have to find them first. That's in and of itself a big technical issue. If we don't know who the PCP is, certainly this PCP is not expecting a call from us. And the person who is making that call not only has to provide the unexpected results to that primary care provider, but has to provide those results along with recommendations for the next step in care. At the same time, another 6 phone calls are being made in other PCP offices with still high-risk reports that require action. And this continues every day, about 6 days a week. Every 3 minutes, 7 calls, more than 2 calls a minute. All the more reason for us to ensure that our public health policy decisions that are made prior to these calls are well-founded. So basically, we want to know what the purpose is of the testing that's being proposed. How do we relate our pre-analytic decisions to the post-analytic reporting. And we know that when we're doing newborn screening that the condition that we're looking for is not just one condition, it's a spectrum of disease. And so the results that we're handing out are not always that clean. So what is it that we're looking for? And what is it that we're hoping to accomplish with all of these new, existing, or new molecular analyses? So let's talk a little bit about the current uses of DNA testing in the newborn screen. I think of this as having typically 3 types of purposes. Of course, the one that's the most promising is that we might be able to use DNA testing to enhance the capacity of screening for conditions that are not otherwise included. All of those conditions that don't have a biochemical analyte that's easy to screen for. And the SCID assay, the TREC assay screening for SCID, is a really good example of this, where DNA testing is used in the first tier of the screen. We might also use DNA testing in the second tier of the screen to enhance the specificity of a first tier test. So a good example of this is where we're using CFTR mutation assay to enhance the specificity of the IRT testing, which is the first tier of the newborn laboratory screening algorithm. Or we can also use DNA testing, and we do use DNA testing as just-in-time information, supplemental information, where we provide the DNA testing information, test results, to a specialist to aid them in their clinical evaluation right after the newborn screen, because all of these results are available before the clinical evaluation. The GALT mutation assay is an example of a DNA assay used in the second tier of the screen for supplemental just-in-time information. Regardless of this, in current DNA testing that's used in current newborn screening programs, the DNA testing target might be a specific genetic allele, it might be a specific DNA structure, it could be a foreign element. The test could be qualitative, it could be quantitative. And like other targets that we use in newborn screening, these assays can be multiplexed. So let's talk a little bit about how we use DNA testing in current newborn screening programs for conventional genetic assays, conventional genetic reporting. And for this, I'm going to focus on a monogenic trait, cystic fibrosis, and how we use some of the data from CF testing. In New England, we started CF testing in 1999. We've identified 450 babies who have cystic fibrosis. Anyone in newborn screening who is using DNA as part of the CF laboratory testing algorithm is more than likely testing for multiple DNA variants. In New England, we're currently testing for 39 mutations. If we were only testing for delta F508, the common allele, we would have identified 85% of these babies, because only 15% of CF babies do not have the most common allele. If we look at the numbers of babies where our testing using 39 mutations will identify 2 CFTR mutations, 75% of these babies are going to have a preliminary diagnosis because we find 2 mutations. We find 2 mutations at the newborn screen. 25% of the babies, we're only finding 1 mutation, but that's still a positive screen. These babies still have a positive screen, and whether they have 1 mutation or 2 mutations at the newborn screen, they deserve a second test, an independent test, before they go on to treatment, to make sure that they actually do have CF. 2 mutations, maybe there are 2 mutations on the same chromosome, who knows what. In order to find our 450 CF babies, we identified 5,000 carriers. 5,000 carriers. That's a lot of carriers. That's only testing 5% of the population, because remember, we're using a biochemical analyte first. So we're only taking the top 5% of IRT concentrations and testing only those babies for the 39 mutations, 5,000 carriers that phone rang in that PCP's office. But CF is a relatively common condition, and the biochemical analyte IRT, it's really not that specific. It's wonderful for CF if we have the specificity of DNA, but it's really not that specific. So there are caveats. If the condition's less common, if there are better first-tier tests, how the testing is used. Is it being used to increase the specificity, or is it being used as just-in-time testing? Will really have a big impact on how many carriers are identified. But again, all of our current conditions are pretty much monogenic traits. Most of the DNA variants, all of these carriers are very well characterized variants. So when we're calling them out, these are, people know what to do with the information. The genetic counselors have a knowledge of what this variant is likely to be associated with. Because of this, as I said, we have a multiplicity of testing, but even our DNA testing is variable. We have different platforms for DNA testing. We have different levels of development. We have different kinds of ways of doing validation of the DNA tests. We have different levels of quality assurance for these DNA tests. We have different ways of using these DNA tests. So is next-gen sequencing our holy grail? Is it our black box? Could be. I mean, certainly it offers the opportunity that that we might have just one platform. And wouldn't that be nice? Or would it be nice? One platform, one set of reagents, what happens if that doesn't work? Can we not do screening anymore? Or is it better to have multiple platforms? Next-gen sequencing certainly needs to have, there are things that are yet to be determined. As far as analytic validity goes, I think it's pretty promising. We do know that there are issues with large deletions and issues with reading through rearrangements and copy number variants, but when it comes to conditions that we can't screen now, we can look at this as the cup being half full instead of half empty. I mean, it'd be great to have additional information. The analytic validity in high throughput situations, such as what occurs in newborn screening programs, well, this also is very promising. But how are we going to use it? Are we going to use it? Are we going to generate it like a scan, or are we going to use to target specific genetic sequences that we want to use? There are choices to be made. I know in the newborn screening program, we need to have the capacity to have flexibility both on choice of conditions and choice of variants that we're going to be reporting on. There is still a lot to be learned. The clinical validity associated with all these variants, boy, that's wonderful. But the knowledge base is growing. That's wonderful, and any of these benefits should be universally applied, and to ensure such, we need funding. We need funding to ensure that there's effective program integration, and that's no less important than all of the pilot programs that we ran to incorporate tandem mass spec, SCID, newborn screening, whatever. As to bioinformatics, how are we going to use the bioinformatics? Well, a lot of that is going to depend on how we're going to incorporate or next-gen sequencing itself. Are we going to be testing everything? Are we going to be doing scans? Or are we going to be doing targeted? Are we going to be selecting targets for first-tier screening that the bioinformatics is going to help us to push that out as reports? Or are we only, or in addition, going to have a bioinformatics setup that will allow us to data mine information that's already been generated to help with clinical inquiries? What are we going to do with updates, and how are we going to deal with record keeping? Newborn screening programs are already, and especially right now, all those college kids who want to participate in college sports, who, oh my goodness, we are being inundated with inquiries for, please give me my sickle cell tests that were generated 20 years ago in a different database than what we have now. It's not trivial. It's not trivial, but it's real. Let's talk a little bit about our current reporting. Our current reporting, I'd like to think of, happens in two different types. There are what I think are routine outgoing reports and responses to clinical inquiries. As far as our technical reports go, it's the same technical report with the same laboratory values, the same result interpretation, but we provide different consultation when there's a clinical inquiry versus when we're sending a result out, different fact sheets. Our report contents are regulated by CLIA, and they are guided by CLSI. We are required to incorporate the reason for testing, the disease locus tested, whether the result is in range or out of range, whether the what sequence variants were detected, what sequence variants were tested, what our interpretation is, what our recommended action is. So let's go through this really with an example of our just-in-time testing for galactosemia. Obviously, we're going to have some demographics. This particular baby has out-of-range biochemical results with a very high T-gal that's greater than 50 milligrams per deciliter and no enzyme present. So this baby is at high risk for classical galactosemia. This baby had DNA testing and showed 2 pathogenic variants, and the pathogenic variants are indicated here along with the listing of all of the 9 mutations that we tested along with this for this baby. The interpretation is that the baby had results consistent with classical galactosemia, which is very different from this baby who might have had the same T-gal result, but then has a pathogenic mutation and mutations thought to be benign. This baby, who might have had the same T-gal results, has to be advised that there is likely to be other mutations that we didn't test. And certainly, and this is a third baby who might have had the same T-gal results where no mutations or variants were detected by the screen, but we need to warn them that you can't rely just on the DNA results. You've got a biochemical result that puts this baby at extremely high risk. You need to act on the biochemical results. The DNA results are really supplemental. So again, remember, this is unexpected. What is yet to be, these calls are unexpected. What's yet to be mentioned is our timeline. When we get specimens in, when we have rapidly progressing conditions, the specimen comes in, we have preliminary results that day that are called out that day. Very, very high throughput, very, very high level of responsibility. But screening really is just a risk assessment process. It's a risk assessment system that has multiple levels of action that ensure that in yellow we have good specimens to work with, that in blue that babies whose results are suspicious are followed up on, and that in pink babies whose results are very highly suspicious, that those babies get into treatment and diagnostic evaluation. So what are we going to do for the future? How are we going to deal with next-gen sequencing? Obviously, there are different topics that need to be addressed. As to the high throughput, I mean, here's just a sampling of a variety of different laboratories that already are doing very high throughput testing. And just looking at what we can generally call 30 conditions, some of these labs are doing about 6,000 tests a day, 6,000 tests a day. Some are doing 70,000 tests a day. 70,000 tests a day that require reporting. As to the molecular level of testing in the United States? Well, I would say it's very well underway. In the U.S., 42 states are already using DNA testing in the second tier. 12 to 14 states are already using DNA testing in the first tier. And those 12 to 14 states account for more than half of the U.S. birth population. 2 to 3 million babies are already having DNA testing performed by state laboratory programs that are doing this universally in a central lab, ensuring equity in standardized, quality-controlled situations that are proficiency tested, all in compliance with CDC proficiency testing for these assays. This is an incredible feat. These DNA tests are done on 3 microliters of whole blood, and 3 microliters of whole blood generating sufficient DNA for a multiplicity of tests. So from a technical point of view, can state newborn screening programs do this? Yes. Much of this was accomplished with pilot funding from the federal government. As to clinical expectations, many of us, this is more than on our radar. We already have, in concert with our clinical colleagues, many of us have our lists of conditions, our likely genes, our known pathogenic variants, our targets that we think, would constitute something that we would want to be reporting at the pediatric level. Are all of these for push-out reporting? Maybe not. Or will some of them be better used for the kinds of screening where we are generating the data and waiting for the clinical inquiry and then doing a data mining? Probably. How that's going to play out, where does next-gen sequencing fit within newborn screening? Yet to be determined. Newborn screening really is about managing risks to allow the most good for the most kids. I'm quoting Stan from Iowa. It's all about managing risks. The technical advances for reporting and follow-up, newborn screening programs are already well on their way to having all of the laboratory information systems that are capable of handling large amounts of data, large amounts of DNA data, electronic data. All of this can be done. But we know from newborn screening that the super high risk babies and the babies who have normal results, or pretty much low to normal results, they're the easiest to report. The ones that are the most difficult to report are all of those in the middle, all of those results that, we don't really know what to do with this. We don't really know what this means. And when it comes to opening up that Pandora's box of all the information that we're going to generate, a lot of that rests right there. How we do that and when we do that responsibly, that's what generates public trust. And that's what will mean continued success of newborn screening. Thank you.